ஸ்டாலின்,
Yes, sir.
நான் உங்களை இப்போ ஹோஸ்ட் பண்ணிடுறேன். நான் இது லைவ் போட்டேன்.
Okay, sir.
நான் உங்களை ஹோஸ்ட் பண்ணிடுறேன். நான் உங்களை.
Okay, fine, sir.
Okay.
Okay, sir. Yes, sir.
ஸ்டாலின், நான் லீவ் பண்ணிக்கிறேன்.
Okay, sir.
நீங்க பாத்துக்கங்க.
Okay, sir.
Okay, thank you.
So, ma'am, shall we start, ma'am? Yeah, ma'am. So, very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. Our topic for the day is hyperglycemia in pregnancy screening. I request the participants to post their queries in the comment box so that we can have a short Q&A session at the end of the presentation. Now it's time to introduce our invited speaker for the day, Dr.Shailaja ma'am. Madam has completed her MD DGO and madam is currently working as an associate professor in Andhra Medical College, Visakhapatnam. And madam is the secretary of OBG Society, Visakhapatnam. Madam is also the organizing joint secretary of UA Foxy South Zone 2020. Madam has fellow in ICOG and presented papers in various state and national conferences. Madam's special interest is practical obstetrics and high-risk pregnancy. With this introduction, I welcome you, ma'am. Ma'am, before going to section, I would like to showcase our web page, ma'am. So it will be like, yeah, ma'am. So Shield Connect is a new initiative of Shield Healthcare, and it's a digital platform with all updated information from menopause to menopause. Ma'am, it has blogs. The blogs from various experts are available in our webpage. So then all our webinars are conducted through our Shield Connect webpage only, ma'am. So you can find the information about the upcoming webinars and the details of the past webinars in our webpage. And we have a special page for PCOS awareness. So you can find a short video of various experts speaking about PCOS in various regional languages. And we have a special page for our leaders. We have more than 220 leaders from the country supporting our company and our webpage by giving their opinions. And I request the participants to go through our webpage and make use of it. Thank you, ma'am. Now you can, I'm handing the session to you, ma'am. You can start presenting your presentation.
Thank you, Dr. Stalin. Shall I share my screen?
Yes, ma'am, sure, ma'am.
Is this okay?
Yes, ma'am.
Good evening, everyone. First of all, I would like to thank Shield Healthcare for giving me this opportunity. And in the next 20 minutes or so, I'll be talking on screening for hyperglycemia in pregnancy, its importance, the various protocols, and the cutoff values for diagnosing gestational diabetes. Doha Society, that is the International Society for Developmental Origins of Health and Disease, postulates that intrauterine and early infant environments have a permanent conditioning or a programming effect on the body or body's metabolism and health later in life. And pregnancy is considered as a window to future health. And we see different physiological changes that occurs during pregnancy, and these actually act as a natural stress test for to the body of the pregnant woman. And one of this natural stress test or this physiological change that occurs in pregnancy is the glucose intolerance, which leads to hyperglycemia. So hyperglycemia is pregnancy is one of the most common medical conditions women encounter during pregnancy. And this is actually a broad term that is used for the various glucose dysregulations that are seen during pregnancy. And FIGO divides hyperglycemia in pregnancy into diabetes in pregnancy and gestational diabetes mellitus. Both of them can be either present as the type 1 or the type 2 diabetes mellitus. So let's see what is DIP or the diabetes in pregnancy. If hyperglycemia detected for the first time after the onset of, prior to the onset of pregnancy, or hyperglycemia detected anytime during the course of pregnancy, but it has to meet the criteria for the diagnosis of diabetes in a non-pregnant state as per the WHO's definition. So what is the criteria that has to be met? The fasting plasma glucose has to be either equal to 126 milligrams, equal to or more than 126 milligrams percent, or a 2-hour post 75 grams oral GTT has to be equal to or more than 200 milligrams percent. Or the random plasma glucose levels has to be equal to or more than 200 milligrams percent for the diagnosis of diabetes in pregnancy. So what is gestational diabetes mellitus? It is hyperglycemia detected for the first time during the course of pregnancy, and they should not be any prior history of diabetes in that particular woman. And it also should not meet the criteria for the over diabetes. Though gestational diabetes can occur anytime during the course of pregnancy, but it usually is diagnosed between the 24 to 28 weeks, where the glucose intolerance is at its peak. So according to the statistics, 1 in every 6 pregnant women suffers with hyperglycemia in pregnancy, out of which 84% are of gestational diabetes. If we see the prevalence of gestational diabetes around the world, it varies from less than 3% that is seen in Sweden and to more than 20% that is seen in Southeast Asian countries and in US and in Alaska. If you see the scenario in Asia, the prevalence of gestational diabetes varies around 11.5%, highest being in Taiwan 38.6%, lowest in Nepal 1.5%, followed by Japan. And Southeast Asian women are prone for developing gestational diabetes because of their genetic predisposition and also by their ethnic background. And not only these, the maternal age and the BMI also adds on to their higher risk when compared to Caucasians. If you see the scenario in India, the overall prevalence of gestational diabetes varies from 4% to 18%, highest in the urban areas, varying from 4.6% to 14%, lowest in the rural areas. And it is seen the prevalence is very low in the Kashmir, that is 3.8%, high in Tamil Nadu, 7.9%. And in the recent studies, it has been shown that the prevalence of rate is as high as 35% in Punjab and 41% in Lucknow. And Indian women are genetically predisposed to develop gestational diabetes, and not only the genetic factor, the other factors like the maternal age, obesity, the dietary habits, and the lifestyle all adds on to the higher risk in Indian women. And it is estimated that the prevalence would increase to 20% 20% in near future, that is 1 in every 5 pregnant women will be suffering with gestational diabetes. If you see the risk factor, there are the modifiable risk factors and the non-modifiable risk factors. And the modifiable risk factors are the overweight, obesity, the pre-pregnancy body mass index, the metabolic syndrome, and the dietary habits. When there is history of PCOS, they are also predisposed to develop gestational diabetes and preeclampsia, and women who are on antidepressants are prone for developing gestational diabetes. The non-modifiable risk factors are the maternal age. With increasing maternal age, the risk also increases. Increasing gravidity and parity, the risk increases, ethnicity, and even the family history. When there is a family history of hyperglycemia, these women are prone for becoming diabetic in their pregnancy. If you see the impact of gestational diabetes on women, studies show that 41% of these women with gestational diabetes have 41% chances of recurrence of gestational diabetes in the subsequent pregnancies when compared to 4% when there is no history of gestational diabetes in the previous pregnancy. And in this study published in 2018, it shows that these women with gestational diabetes are prone for becoming, prone for developing disorders of glucose metabolism when they are followed for a long term. And 1/3 of these women with gestational diabetes are prone for developing metabolic syndrome when they are followed for 5 to 10 years after their delivery. They are also at risk of developing type 2 diabetes mellitus when compared to the normoglycemic pregnant women. So women with gestational diabetes, not only that, the women with gestational diabetes also are prone for developing cardiovascular diseases when they're followed for more than 10 years after delivery. So if you see the impact of gestational diabetes or hyperglycemia in pregnancy in the future generation, studies show that this is a study that is published in 2003, Lancet, shows that exposure to a diabetic environment in utero is associated with increased occurrence of impaired glucose tolerance and defective insulin secretory response in adult offsprings, and this is independent of the genetic predisposition to type 2 diabetes. And these babies are prone for developing type 2 diabetes in their future, and this study shows that 45% of these children born to mothers with gestational diabetes developed type 2 diabetes at the age of 20 to 24 years. And babies born to diabetic mothers are taller, heavier, with a higher BMI, and 32% with a more total body fat mass, and 7.5% more total body lean mass when compared to the controls. And therefore, gestational diabetes is considered as a harbinger of a vicious cycle of obesity and diabetes. That means women with gestational diabetes give birth to children who are large for gestational age, and they are prone for developing obesity in their adolescence and adulthood. And female babies are prone for developing not only obesity, and they are also prone for developing PCOS. And when they become pregnant, there is a higher risk of developing preeclampsia and again gestational diabetes. So this cycle, as this cycle continues, it is estimated that in the overall prevalence of diabetes mellitus over the world increases to 51% by 2045, and in Southeast Asian countries it might go around 74% by 2045. And if see the scenario in India, the figures, which is around 77 millions in 2019, may go to as high as 134 millions by 2045. And not only that, the prevalence of the overweight among the children and adolescents between the ages of 6 and 19 years will rise from 20%, which is seen in 2019, to around 30% by 2025. So this is very important to put a stop or to break this vicious cycle of transgenerational obesity and diabetes. So these are the three critical window periods of opportunity to break the cycle. And the most important among this is the early screening of gestational diabetes and maintaining euglycemia, so that the babies are not born with large for gestational age babies. So there are different protocols, see, all over the world by all the different organizations and professional bodies for follow different algorithms and different protocols for screening and diagnosis of gestational diabetes. Even in a particular country, the endocrinologists, diabetologists, and the obstetricians all follow different protocols and cutoff values for the diagnosis and screening of gestational diabetes. So this is actually all these recommendations so far present are criticized, and they are lacking because they lack validation, and these are mostly formed or framed based on the opinions of the experts. So all this creates a confusion and uncertainty among the healthcare providers. So the basic underlying problem for this total confusion is, as it is shown by different studies, as including the HAPO study, is that the risk of per pregnancy outcome associated with hyperglycemia is continuous, and there is no clear-cut inflection point. Some follow the universal screening procedures, or some follow the selective screening. Selective screening, it is usually followed in, or it is better to follow in populations where there is the risk for gestational diabetes is low, because subjecting all pregnant women for a lab test may be considered as not cost effective. So this is popular in the European countries, but the sensitivity of this one is poor when it is applied to countries where the prevalence is very high. And as this protocol, like selective screening is, you just first find out the women who are at risk of developing who are at high risk for developing gestational diabetes, and then subject them to the lab test. So this is a complex protocol. So the compliance among the, not only among the patients, but also among the healthcare workers is very low. The universal screening or the universal testing, this is it is better to use it in a population where the prevalence of gestational diabetes is very high, and because 90% of pregnant women have at least one risk factor, and 20% of pregnant women with gestational diabetes may not have any risk factor. So FIGO recommends universal screening in low, mid, and middle resource countries. For example, in India, if you see, approximately 27 millions of births takes place in a year. That means 27 million oral GTT tests has to be done. This appears like a huge burden on the healthcare system, but when it is compared to the burden that is produced by the long-term implications of gestational diabetes, it is definitely cost effective. And some follow the one-step protocol and some follow the two-step. One step is subjecting all pregnant women to directly either the 75 or the 100 grams oral GTT. The two-step procedure is first the screen with the 50 grams glucose challenge test, and if it is positive, then subject them to the 100 grams oral GTT. So if you see the advantages of the one-step procedure, it is simple to follow and a better patient compliance and easy to diagnose, and it is also very sensitive. And disadvantage of this one is not cost effective, especially when it is used in countries where there is the prevalence is gestational diabetes is very low. And there is a little more chances of false positives, that is overdiagnosis of gestational diabetes may occur with the one-step procedure. And the two-step procedure advantages, less number of false positives, and you can avoid oral GTT in 75% of all pregnant women. But this is the compliance is less in patients because they have to come to 1 or 2 times to the facility to get themselves tested, and the sensitivity is only 75% when compared to the one-step procedure. Therefore, there is a chances of 25% missing the diagnosis of gestational diabetes, and also because it takes a 1 or 2 days or visits, the initiating of treatment also gets delayed. So these are all the various screening tests and protocols that are advised or given by different guidelines, the WHO guidelines, the International Association of Diabetes in Pregnancy Study Group, ADA, the ACOG, NICE guidelines, the DIPSI guidelines. There are different protocols are given. But what FIGO recommends? FIGO recommends that all pregnant women should be tested by the one-step procedure, and the universal screening of all pregnant women for hyperglycemia has to be adopted. And FIGO also adopts the WHO 2013 criteria for the diagnosis of diabetes in pregnancy. That is, the fasting plasma glucose has to be equal to or more than 126 milligrams per cent, and the 2-hour post 75 grams oral GGT has to be equal to or more than 200 milligrams per cent, and or the random plasma glucose has to be equal to or more than 200 milligrams per cent for the diagnosis of diabetes in pregnancy. And FIGO also adopts the WHO 2013 criteria for the diagnosis of gestational diabetes. That is, this is also a one-step procedure where 75 grams oral GTT is test is used. And the test has to be performed in between 24 to 28 weeks of pregnancy. And any one of the, if it meets any one of the criteria, that the diagnosis is taken as positive, like the fasting plasma glucose, if it ranges between 92 and less than 125 milligrams per cent, or the first hour post 75 grams oral GTT has to be equal to or more than 180 milligrams per cent, or the 2-hour post 75 grams oral GTT more than 153 milligrams and less than 199 milligrams per cent for the diagnosis of gestational diabetes. FIGO also recommends different protocols based on their resources available per that particular country. So in India, Indian subcontinent, FIGO recommends the DIPSI guidelines for the diagnosis of gestational diabetes. So what is this DIPSI guidelines? So here, all pregnant women at booking or at the during the first trimester has to be screened for gestational diabetes, and whether the woman comes in fasting or in a non-fasting state, the 75 grams oral GTT test has to be done, and the 2-hour post 75 grams blood sample has to be tested for the glucose levels, and the value, if it is more than 140 milligrams or less than 199 milligrams per cent, it is indicates that the person has gestational diabetes. So if it is more than 199, it becomes the diabetes in pregnancy. So if the test shows that the value is less than 140 milligrams per cent, the test has to be repeated again between 24 to 28 weeks. So why DIPSI has not included the fasting plasma glucose as one of the criteria for the diagnosis of gestational diabetes? Because we all know that all antenatal women never come to their checkup in a fasting state when they come for the first time. And when these women are asked to come again in a fasting state to get themselves tested with the oral GTT, there is a high chance of dropouts. And if the diagnosis is made based on a single fasting plasma glucose, this creates an emotional disturbance not only in the patient but also in their families. And it is shown that fasting plasma glucose levels do not reflect the 2-hour post 75 grams oral GTT, which is supposed to be the hallmark of gestational diabetes. And in pregnancy, the elevated postprandial plasma glucose levels is more predictive of the potential fetal macrosomia and morbidity when compared to fasting or the preprandial levels. So, and not only that, Indian women who are at risk, genetically predisposed to develop diabetes in their, who are genetically predisposed to develop diabetes, they have a more accelerated insulin resistance during pregnancy. So taking the fasting plasma glucose for the diagnosis of gestational diabetes may not be appropriate. And taking 92 milligrams as the cutoff value for the diagnosis, there is every chance that 76% of the diagnosis of gestational diabetes may be missed. So even the WHO recommends that in Indian women, depending on the fasting plasma glucose as one of the criteria for the diagnosis of gestational diabetes is not adequate. And even in the recent studies done by Anderson et al., it shows that a single fasting plasma glucose level for the diagnosis of gestational diabetes is insufficient and also not appropriate. So why DIPSI has considered as 140 milligrams as a cutoff value for the diagnosis of gestational diabetes? So if you see the HAPO study, this here it has been clearly shown that the increase of any of these, either the fasting or the 1 hour post 75 grams or a 2 hour post 75 grams, the increase in any of these values is associated with a graded increase in the adverse pregnancy outcome, whether it is the the weight of the baby or the C-section rate or the fetal insulin levels or the neonatal fat content. That means this the fetal morbidity or the fetal diabetopathy, this starts even at a lower level than 140 milligrams percent, when the maternal plasma glucose levels is even at a lower than the 140 milligrams percent. See all over here, it is seen that there is increments are seen even before the 140 mark. And in this HAPO study also shows that the odds for developing diabetic fetopathy is 1.5 when the 2 hours post 75 grams oral GTT is 142 milligrams percent. And the odds for developing diabetic fetopathy is 1.75 when the level is 153. So this criteria is been taken as a cutoff value by DIPSI because Indian women are genetically predisposed to develop diabetes. Frank et al. In their recent studies have also shown that 19% of the babies develop type 2 diabetes at the age of 24 when their maternal plasma glucose levels were between 120 to 139 milligrams percent, and 30% developed type 2 diabetes when their maternal plasma glucose is more than 140 milligrams percent. And therefore, it is very important to consider this 140 as a cutoff value for the diagnosis of gestational diabetes. So values more than 200 milligrams percent is considered as diabetes in pregnancy or the over diabetes. And between 140 and 199 milligrams percent, it is considered as gestational diabetes, and less than 140, that is 120 to 139 milligrams, it is considered as intolerant. So these women may develop gestational diabetes in next pregnancies or may develop type 2 diabetes mellitus in their future. And this study done by Veeraswamy Seshaya et al., it shows that the criteria used for the diagnosis, DIPSI criteria used for the diagnosis of gestational diabetes are equally effective when compared to the WHO 2013 criteria, either in the detecting the number of gestational diabetic women or in the number of women with the gestational diabetes which are missed. And if we see the number of large large for gestational age babies that are detected are also equal in both the studies, and those who are where there is prevention after treatment also is also same. So this DIPSI guidelines is equally effective in diagnosing gestational diabetes when compared to WHO criteria. So the Indian government in 2014 postulated these national guidelines for the diagnosis and management of gestational diabetes. And in 2018, this diagnosis and management of gestational diabetes is integrated with the antenatal care in the public health system. So according to this one, the target population, all pregnant women should be tested for hyperglycemia in pregnancy. And the protocol that has to be used is they have to be tested twice during their antenatal period. And the first test has to be done as early as possible in pregnancy or in the first trimester, or when the woman comes for the test for the first time to the checkup. And the second test has to be done between 24 to 28 weeks of gestation. And if the first test is negative, and there should be a gap of 4 weeks between the two tests. And if the woman comes late in pregnancy, then also you do the test beyond, and if she comes beyond 8 weeks, one test is sufficient for the diagnosis of gestational diabetes. And all these tests has to be performed in the Pradhan Mantri Surakshit Mantritva Abhiyan sites as per the protocol. And what is it? How is the test to be performed? It is a single step procedure where 75 grams oral glucose has to be mixed with 300 ml of water, and this has to be consumed by the woman within 5 to 10 minutes. Whether the woman comes in fasting or non-fasting state, irrespective of her last meal. And if the woman vomits within the first 30 minutes after consuming the glucose, the test has to be repeated on some other day. And if the vomiting occurs 30 minutes after the test, then you can continue the test. And the blood sample has to be drawn 2 hours after the ingestion of the oral glucose, and it has to be tested with a glucometer, and you don't have to go for the analyzers. Just standardized glucometer is enough for evaluating the blood glucose. And the cutoff value here is if it is more than 140 milligrams per cent, then it is diagnosed as gestational diabetes. So the pregnant woman is tested, and if it is more than 140 milligrams per cent, managed according as per the guidelines that are given for the management of gestational diabetes. And if it is negative, the test has to be repeated between 24 to 28 weeks. And if it is positive, then you go manage it like gestational diabetes. And if it is negative, then you go managed like any other antenatal case. And this study by Hema Divakar et al. Is actually conducted in all the medical colleges all over India to determine the current practices that are being followed for the diagnosis of hyperglycemia in pregnancy. And the results show that 95% are aware of the universal testing, and only 70% are aware about the single step procedure, and among this 21% are aware that the glucometer has to be used for the testing, and it has been also shown that the paramedical staff, whether the staff nurses or the lab technician, only 12% are aware about the DIPSI guidelines, and all these are of the most of them, like 91%, are of the opinion that all these medical and the paramedical staff needs a training for the screening and management of hyperglycemia. So to summarize, women with Indian ethnicity are more prone for developing hyperglycemia in pregnancy, and the high incidence of type 2 diabetes, the origin lies in the hyperglycemia in pregnancy. And the studies confirm that there is still a very wide variation in the testing practices all over India for the diagnosis of hyperglycemia in pregnancy, or the gestational diabetes in pregnancy. It is very important to adhere to the FIGO, FOXY, DIPSI, Government of Indian guidelines for the screening of gestational diabetes. And for this, it is better to start some training initiatives towards the nurses and the lab technicians, as well, the medical personnels as well. So thank you very much for hearing.
Thank you, ma'am. Thank you very much for the presentation, ma'am. The clinical management of women with GDM is a challenge, and it puts additional stress on the healthcare system, ma'am. So early screening can avoid the complications in pregnant ladies. So thank you for that wonderful presentation, ma'am. Ma'am, it's if you allow me, then I will read out the questions, if any, in
Yes.
the comment box.
Sure.
The delegates to post their queries in the comment box. So if you have any queries in the guidelines or anything in the presentation, then you can just post us in the comment box. Let me wait for 1 or 2 minutes for the participants to post the queries, ma'am. Ma'am, I could not find any other questions in the comment box, ma'am. Ma'am, if you allow us, then we can end this webinar for today, ma'am.
Yeah, sure. Please.
Thank you, ma'am. Thank you very much for your presence and your spending your valuable time with us today, ma'am. On behalf of Shield Healthcare, I would like to thank you and all the delegates for their patient listening, ma'am. Thank you, ma'am. Thank you, ma'am.
Thank Shield Healthcare for giving me this opportunity. Thank you, Dr. Stalin.
Thank you, ma'am. Thank you so much. Thank you for the excellent talk. I suppose everything you have mentioned in the presentation, which has been quite lucid and easy for everybody to understand. Thank you so much for guiding everybody. Thank you, ma'am. Thank you for your time, ma'am.
Thank you very much.